So when we're talking about geriatric patients, again, most of your care is going to be the same. Just like with pediatric patients versus adult patients, then geriatric patients versus adult patients, it's kind of, you've got the same patients, you've got the same basic things that you can do. It really comes down to a difference in what you might see as far as problems, as well as the way you might interact with them communication-wise in order to properly treat them. Just like how we talked about with infants and pediatric patients, you want to be careful that you don't talk down to geriatric patients or somehow pretend like they're not there and talk about them. That same amount of respect that you give to every other patient still applies, even if they are elderly and, and in pain or otherwise having issues. Okay, so when we say elderly or geriatric, we're not really talking about any specific age range. We're not going to give you a number that you need to call geriatric versus other patients. This is just kind of generally things you might see with age, with aging patients. After about age 30, your body begins to decline. So your organ systems will lose 1% of function every year. Your body becomes less capable of uptaking things like calcium and other nutrients. Your body just is no longer able to quite as efficiently deal with stuff that happens to it. Your heart rate will in general decline. Obviously, this depends person to person, but overall, over the course of time, heart rate, heart functionality will decline. What that means is that an older patient who's got some sort of internal bleeding or shock or something isn't going to look quite like you might expect for a younger patient who's experiencing those same things. Because their vital signs are a little bit different, it's not going to look quite the same from the outside. Okay, so if you're communicating with an older patient, you be aware that they may have some difficulties in terms of communicating with you. Changes in their hearing and their vision might make them more difficult, or might make it more difficult for them to communicate with you. Changes in memory, so they may not remember everything very well. Patients who are elderly and are having memory problems tend in general to become kind of distrustful because they just don't remember everything that's happened to them or is happening to them. And overall, they feel a little bit more disoriented usually. You may also have actual physical changes in terms of loss of teeth. So a patient who has lost some teeth or is wearing dentures or something is going to talk differently than a patient who has all of their teeth. So be aware of that. Listen carefully when you're talking to these patients. Don't just kind of assume that they're talking gibberish just because you can understand them. Like I said, changes in memory, loss of brain function. A patient with Alzheimer's or dementia is going to communicate with you differently than a patient who doesn't have those issues. That is why, because you won't know necessarily, you won't know what their Alzheimer's or dementia is, you won't know if they have it or if they don't just chalk up any sort of altered mental status to, oh, well, they're just old. Oh, well, they probably have Alzheimer's, don't worry about it. Don't just assume that, because that's not necessarily true or fair. Any patient who is elderly, quote unquote, and shows altered mental status, start off first with the idea that their altered mental status is caused by whatever is currently causing them a problem, their current illness or injury. It may turn out that it's not. It may turn out that they have Alzheimer's and they're always a little bit off in terms of what we might expect, but you don't want to assume that from the get-go because you might miss something important. So when you're assessing an older patient, you assess them exactly the same way. See and size up, primary, secondary, identical. When you're doing your scene size up and safety, look inside and outside of the residence for any sort of clues that might lead to extra knowledge about this geriatric patient. So the condition of their residence, both inside and outside. We're talking cleanliness, overall state of repair, any other things that you notice that might seem out of the ordinary. Maybe, in other words, that they weren't able to properly take care of it. Half-eaten food, dirty house, whether it's dirty or clean. These are all going to maybe give you signs if a patient is having difficulty, whether through Alzheimer's or some other physical limitation. If they're having difficulty properly taking care of their residents, that may give you a sign into what else is going on with them. Be watchful for any items left out that the patient can trip on for their safety as well as yours, as well as overall kind of gives you another idea of are they properly taking care of their environment and being careful within their environment. When you're assessing a patient, again, take their general impression, take their mental status, but don't assume that if their mental status is altered, that it's just because they're old. Airway, breathing, circulation, you assess the same as you would normally. You want to go ahead and be careful about checking for priority patients. Older patients are less likely to show really severe symptoms. They're less likely to report really severe pain. Usually they don't notice it as strongly. What a younger person might rate as a 9, they might rate as a 6. Their nerves aren't quite sending quite as strong of signals, and so it feels a little bit different to them. So it may be a little bit more difficult to determine if they're a priority patient, to determine if what they're feeling is really a heart attack or if it's something else. They may have what's considered a silent heart attack, which means less symptoms overall. They may not feel any pain. It may just be a slight shortness of breath or something like that. So be alert to the fact that it's going to be a little bit harder to identify what's really wrong with them and take that into consideration. So keep what we call a high index of suspicion, meaning be super suspicious that one of these things might be a concern. Don't just assume it's all hunky-dory because they're not really reporting anything super wrong. When you're doing your secondary assessment, take the time that you need to get a full history of your patient.
I'll call you.
Okay. They're going to have a longer history than somebody who's half their age. That just makes sense. Ask them the questions that you need to get, like I said, a complete history, even if that means asking questions farther back, emphasizing, okay, what about in the last 20 years or something like that? Because they may just be thinking immediately, or they may be thinking about their current problem and not giving you an overall picture of the history of their heart health, for example. You want to go ahead and find out whatever medications they're taking. A lot of elderly patients have like bags or bins full of their medications or entire lists with all of their medications and dosage and everything on them. Patients who have a lot of chronic illnesses, you'll see this. They keep everything really easy to grab, to bring to their doctor or whoever they're seeing that day to make sure that that person has all their information. So if you get one of those, you're lucky. If you're handed a bin full of medications or a list full of medications, makes your job a little bit easier. If your patient doesn't have that kind of thing, you want to go ahead and attempt as best as you can to get a medication list from them. Look around for any bottles that may be around if you're like in their home or in their bathroom. You don't want to go prying and snooping, but if you can find something that is your patient's medication that can help you understand better their medical history, that's only going to do good things for you. You want to go ahead and ask any family members that you can, anyone who's around, if they've got a caretaker or a live-in nurse or just a neighbor who's known them really well, anyone that's around, go ahead and ask them those questions because, again, if they don't remember everything, if there's altered mental status, whether an immediate problem or more of a chronic thing, you may get extra information by talking to the people around your patient as well as just your patient. Here we talk about making sure or finding out whether your patient is compliant with medical advice. Okay, so if your patient is supposed to be taking these medications for their high blood pressure, maybe they have them in their house, but if they don't actually take those medications, that will be good for you to know what you're dealing with. Because a lot of older patients who take a lot of medications don't necessarily want to take all those pills every day. You see this a lot in like older crotchety men. They're just kind of like, no, I know what's good for me. I'm not going to take that darn pill. I don't like the way it makes my head feel. So don't just assume that they're taking the medications. You kind of have to read into your patients the way they're talking and communicating and acting with you. Kind of have to read into that to see if you think that they're complying with medical advice and if you can trust just their testimony versus really needing to find the testimony of others about what's happening with your patient. You would go ahead and do the physical assessment just like you would with any other patient. Keep in mind that even though your patient is older, and I think it's easy for a lot of medical personnel to kind of overlook elderly patients and any sort of dignity or modesty or thing like that. Anything that they might give to a younger patient who maybe is more interactive, sometimes they overlook that with older patients. So remember that your patient is older, but they're not dead. They still deserve that respect and that dignity that you'd give to a younger patient. And they may want it even more. Again, they're feeling very protective of themselves. Give them the opportunity to stay as modest as possible when you're doing your physical exam, and be careful of their feelings. Explain what you're going to do. They may mistrust medicine in general. They may distrust people in general. So just don't assume anything just because they're older. If you have an elderly patient, be aware that you may see more pelvis and hip type injuries. I don't know, does anyone in here know somebody who's got osteoporosis? Really? No? Do you know what that is? Okay, it's essentially a bone disease. It causes your bones to be more brittle. The structure of your bones deteriorates. And osteoporosis literally means like bone holes. So their bones become more brittle and fragile. Even if patients don't actually have osteoporosis, their bones in general do become more brittle as they age. So look for certain things. Look for hip and femur fractures. They're pretty common with falls. When we say a hip fracture, we're actually talking about the femur. So the femur is like a long straight bone, and then it's got the neck, and then the ball, the head, right, makes up the femur. When we say hip fracture, we're usually meaning a fracture right below the ball of the femur. That's most commonly called a hip fracture. So you may see that, or you may see like lower mid-shaft femur fractures as well. Older people do tend to fall a lot because one of the things that goes when your whole body is eventually kind of deteriorating a little bit, your sense of balance goes for sure. And so they fall more commonly. Like I was talking about the weakening of your bones, whether through osteoporosis or some other bone disease or just general age. In general, they're going to have potential of more injuries to their wrists, their humerus, their hands. Why would that be? Exactly. They're trying to catch themselves. So they're losing their balance, they're starting to fall, they catch themselves, and now they've got a broken wrist as well as bumps and bruises and potentially other breaks. You want to check their extremities for edema. Remember the swelling, that building up of fluid, because these may be signs of underlying heart or vascular or liver disease that may not be otherwise apparent in your patient, not as easily because we talked about how their vital signs change. Okay, so along with all the rest of their bones being more brittle and more easily broken, their spine is included in that. You may see what we call compression fractures. You see them in other patients too, but especially in older patients. So a compression fracture of the spine would be the kind of fracture where not like hit laterally from the side or whiplash, but if you fall real hard and land on your feet and your whole spine is literally compressed, you can get a compression fracture as any normal aged adult, but it's even more common in geriatric adults. Be aware of that. They're commonly injured in motor vehicle collisions. Okay, this is something worth talking about. So abnormal curvature of the spine in elderly patients. I'm sure you guys have seen patients whose spines are really hunched over or twisted to one side or another. I think the hunching is called kyphosis or kyphosis. Have you all heard that term? Okay, I think that's what it's called. But if somebody has, I believe, kyphosis, if they have that like hunch to their back, you know what I mean? It's not just somebody who's bending over, but it's like their spine actually kind of hunches up and they're, kind of like this look. It's going to be more difficult to immobilize them how you'd expect with a backboard. So if they're hunched like this, hold on, wait, that might be Randy. Okay, so if the patient has that abnormal like kyphosis curvature like that, you can't just easily straighten them out on the backboard and assume it's not going to cause a lot of trauma or pain to their spine. If their spines are perpetually bent forward, you just can't do that. So you're going to have to pad between the voids, try to keep the vertebrae in alignment, potentially even immobilize them on their side, padding in such a way that their body state or their spine space stays mostly straight, but you're not going to be able to expect them to just straighten out their back fully on a backboard like you can with some patients. Okay, so when you're reassessing patients, or ongoing assessment of patients, again, same thing that you would kind of do with any other patient, especially altered mental status you want to be really aware of, as well as your ABCs, as well as vital signs, checking interventions, things like that. Okay, so we kind of already talked about some of these. Older patients are more prone to certain illnesses and injuries because of those age-related changes, as well as that the problems also look different in an older patient. And the signs and symptoms may not be as clear-cut, like we talked about. A patient who's having a heart attack may not show the obvious chest pain, moving around, radiating to their left arm, and things like that, that we would think of as a heart attack, a classic heart attack. They may report little to no pain, maybe just a little bit of weakness or shortness of breath. Their signs and symptoms just won't look the same. Be aware that a lot of these patients who are taking multiple medications, like I said, they may have a whole nice long list for you. And hopefully they know how those drugs interact, as in their doctors that they've been to are careful to make sure that the drugs that they regularly take don't interact badly with each other to cause problems. However, that's not always the case. So additionally, something that you are giving them as a drug may interact badly with one of the drugs they currently take. Be aware of this. Be aware of these interactions that may happen. Y'all don't have to worry about it so much because as a basic, you don't really give many medications. Paramedics have to worry about it a lot more because they do give a lot more medications and drugs. But at the same time, this is something you want to be aware of. Okay, so if your patient is complaining of dizziness or weakness, and y'all know what malaise is? Malaise. Is it there? Okay, sort of a feeling of, like, I guess, lethargy, not really being able to do anything. Anything from, like, their body actually physically feeling heavy to depression. Those are all kind of covered under that. But if they're complaining of dizziness or weakness or something, don't just assume, oh, well, they're old. That's just because they're old. Don't take those complaints lightly. It may be associated with a very serious condition, or it could even be life-threatening. So even with these kind of weird, vague signs and symptoms that they may report, take them seriously. Do your best to figure out the underlying cause. So elderly patients, maybe surprisingly, maybe not for you guys, actually do commit suicide quite a bit. One of the highest groups in terms of rate of suicide is elderly males. Causes in these elderly patients would be physical conditions or things like that would limit their ability to operate and function normally. Medications that they take that sap their energy, as well as just kind of life events. So a lot of their friends and family are dying, and that's really sad for them. The other changes that age causes within a person may kind of make them feel basically just like they're ready for their life to end. They don't really feel like they have anything left to live for. So you want to watch out for depression in your elderly patients. Watch out for suicidal tendencies and thoughts or signs that they may be contemplating suicide. One thing that you may see more commonly in elderly patients versus other patients is shingles. Do y'all have any idea what shingles are? Has anyone here actually had them? Okay. So shingles are actually caused by the same virus that causes chickenpox. If y'all have seen the commercials for the shingles medications, they mention that. This virus can remain dormant in the person. So if you had chickenpox as a kid, you could potentially have shingles as an adult. And it shows up as a very, very painful, itchy rash, kind of flu-like symptoms. So you're going to see some of the same fever, respiratory issues. And actually, it can be contracted from like the fluid that comes out of the rash or out of the sores. If you as an EMT touch that without your BSI on, you could potentially contract shingles. So be aware if you have a patient who's complaining of this, that painful rash, specifically the belt-like band around the torso. It usually occurs kind of here. Be aware that it may be shingles, and you could potentially get it. So that was shingles. We already kind of talked about falls. Elderly patients do tend to fall more frequently, more commonly. You want to check for this, like with any patient who falls, but again, especially with an elderly patient, that the fall was not just caused by a lack of ability to balance. There may have been some other thing that precipitated the fall. A more serious problem, a stroke, internal bleeding, something causing altered mental status. It's one of those things where you don't want to assume, oh, well, they have altered mental status because they fell and hit their head. Be aware, maybe the altered mental status made them fall, and so whatever caused the altered mental status is actually the largest concern. If a patient falls, they have a lot of opportunities for complications from the fall. Patients already have, again, decreased functionality anyway, but especially respiratory-wise, a patient who falls may get, this is just an example, may get bruised ribs, then can't cough properly because of the pain, then they develop pneumonia or some other respiratory issue. So you want to assess for the cause of the fall as well as the injuries from the fall, both sides. And don't assume that something caused something else. You want to look at the whole problem or the whole scenario. So a patient who is elderly may be losing independence, and that's psychologically one of the issues that they definitely have to deal with. You want to treat them with dignity. We already kind of talked about this, how you deal with those patients. Treat them with dignity. Don't minimize them. Don't talk around them. Respect them. If they're having to leave the house, allow them to, if at all possible, if it's not a trauma situation, allow them to do the things that will kind of help them feel closure about what they're having to do or where they're having to go. So locking up the house, arranging for care of their pets, because they're losing the sense of autonomy that they probably had their entire lives. And so along with whatever illness or injury they're facing this additional psychological issue. Does anyone have any questions about geriatric patients and the issues that we specifically deal with them? Okay.